So welcome back as all of you stroll in and once again get comfortable. I'll spend 1 or 2 minutes introducing our final speaker for this morning session. Thank you for hanging in there. And the old cliche, it's he and I, mostly he, Professor Dr. Peter Hotez is standing between you and the lunch. Now, he offered to, as you know, that the topic is neurological complications of neglected tropical disorders, diseases, and he offered to just give a straight-up Zika virus lecture instead. However, for for administrative and other CME reasons, he cannot do that, but the lecture will be, probably he'll give us an emphasis on Zika virus. Now, you have a long introduction, which I'll make short. First, I'm very grateful to whom I just met, Peter, Dr. Hotez, that he gave me a bio. It saved me about an hour's worth of work trying to sift through all these distinguished speakers' extensive CVs. He's the Dean of the National School of Tropical Medicine, Professor of Pediatrics and Molecular Virology and Microbiology at BCM. He's the Chief of the new section of Pediatric Tropical Medicine, and he has an endowed chair in tropical pediatrics. As you can imagine, internationally recognized physician scientists, etc., etc. Like just about all the speakers this morning, he's at least some point originated kind of from the Northeast, but have all ended up here in BCM. It is undergrad degree at Yale University and then PhD in biochemical parasitology from Rockefeller University and then at Cornell Medical College. He has more than 400 original papers. He's been a previous president of the American Society of Tropical Medicine and is founding editor-in-chief of PLOS, Neglected Tropical Diseases. And the last sentence, he is in the White House and US State Department selected him last year as a United States Science Envoy. So please join me in welcoming Dr. Hotez to give us our last lecture.
Thank you very much. I appreciate, by the way, I don't know if you mentioned it, but I'm also a pediatrician and just got recertified in pediatrics. I had to go to a testing center with like 50 other millennials and take a test, which is not easy to do at my age, but I did it and passed, barely, but I passed. So I'm going to talk to you, give you an overview about this very interesting group of diseases that we don't have a great term for, called neglected tropical diseases. And I did a beta test of this to the child neurology group at Texas Children's, and it was one of these lectures that I asked to give because, you know, in the decades that I've been doing this, I've come to realize that among the most important effects of these tropical diseases is their impact on neurology and mental health. And there's a huge both neurology and psychiatry component to these diseases, which is not intuitively obvious, but that is one of the reasons why these are so important. So I thought I would just give you a kind of brisk 30,000-foot overview of these diseases and why they have such a huge importance on the brain. And a lot of what I'm going to say is hypothesis generating rather than hypothesis confirming, meaning that there's a lot of provocative stuff about these diseases, but very little of it is proven because they're neglected tropical diseases, which means they're not the subject of intensive research efforts, even though they're important, huge causes of global morbidity. So this is, if you're a fellow or if you're a young neurologist thinking about how to make your mark in the world, I think these diseases are going to be a great example of what you can do. Just a word about my day job. I'm based at the Feigen Center of Texas Children's Hospital, where we created the School of Tropical Medicine, but I also develop vaccines for neglected tropical diseases. So we're making vaccines in the nonprofit sector, making the vaccines that the big pharmaceutical companies can't make or won't make because they're for the diseases of the poorest people. So I'm a pediatrician scientist, very focused now on running a big lab group that's developing vaccines. And the way I'm going to start introducing these diseases is to take the policy spin. This is a picture of what are called the Millennium Development Goals. How many people have heard of the Millennium Development Goals? So it is the overarching framework for which all big global health initiatives have been launched. It was started in the year 2000 by Kofi Annan, who was then Director General of the United Nations, and he brought all global leaders to UN headquarters around 15 years ago to launch this set of agreed upon goals, basically focusing on poverty reduction, addressing the plight of a group called the bottom billion, the billion people in the world who live on no money. But what was interesting was the link between disease and poverty. So you can see that 3 of the goals, number 4, number 5, and number 6, are specifically around health issues, recognizing that these diseases not only occur in the setting of poverty, they actually cause poverty, in part because of their impact on child intellectual and cognitive development, as well as mental health. And that's what I hope to go through to today. And the Millennium Development Goals, which just ended, were also very useful from an advocacy point of view, because it got all the beautiful people behind it. It got Bono, and Brad Pitt did a 4-part series for PBS on the Millennium Development Goals. And of course, if you get Brad, you get Angie, and then you got George Clooney. And so it really created a big buzz that helped put a lot of money behind these big initiatives. So I want to focus most of my comments today on a part of Millennium Development Goal number 6, to combat AIDS, malaria, and other diseases, banking on the fact that as neurologists, you've probably already have done a deep dive on the mental health effects of HIV/AIDS and the neurologic effects of this neurotropic virus, but to tell you about the parts that you probably don't ordinarily hear about, which is malaria and other diseases, with recognition that a big component of the other diseases are actually diseases that are endemic in the United States. It's just that they tend to get terribly underdiagnosed. This is a paper that I'm part of. Believe it or not, I'm an author somewhere on there. That's actually half the author list. It's an initiative that comes out of Seattle at the Institute for Health Metrics and Evaluation, which is funded by the Gates Foundation, to look at the impact of all the Millennium Development Goals on actually improving health around the world. And it's coming out as a series of papers in the Lancet, and it involves hundreds of investigators. So the papers that come out look like something out of the CERN physics laboratory, but this is actually one of our papers looking at the impact of AIDS, TB, malaria, and those other diseases. And by the way, when I talk about other diseases beyond AIDS, TB, and malaria, we're referring to a group that we since named the neglected tropical diseases, which is a group of 13 or 14 infections, which has now been enlarged to 17, that are chronic and disabling conditions that have big impacts on neurologic and mental health. And we've done a lot of work both in the laboratory and raising the profile of these diseases, including writing a book on these infections, which my kids like to call Dad's Forgotten Book on Forgotten People with Forgotten Diseases in the upper right-hand corner, but now it's gone into its 2nd edition, just had a Japanese translation. So I'm going to give you, outside of AIDS, TB, and malaria, the diseases that we're talking about. They're among the most common afflictions of people living in poverty. This is ascariasis, intestinal roundworm infection, but a lot of these are worm diseases, 800 million people. This is whipworm, huge numbers, hookworm, and a lot of people are polyparasitized. They don't just have one, they have multiple diseases. Schistosomiasis, foodborne trematode infections, dengue, lymphatic filariasis, onchocerciasis, Chagas disease, leishmaniasis, trachoma, cysticercosis, echinococosis, rabies, sleeping sickness, yaws, Buruli ulcer, and Ebola, ND being not determined, and now we can add Zika to that list. But the one point I want you to remember today is that a number of these diseases exert their pathogenic effects through their effects on the brain, which is, again, not intuitive. So a lot of these diseases are not necessarily killer diseases, but they can be highly debilitating. And we're trying to figure out ways to convey that. This is something that we've done recently working with a group of economists. We've come up with a an NTD index or a worm index of human development to show by country that as your worm index goes up, your human development index, which is a complex metric that includes life expectancy, educational attainment, how you treat girls and women, actually goes down. And now we're providing some evidence that the two are linked, that worms are having and other neglected tropical diseases are having a huge impact on reducing the capacity of humans to engage in productive activity. So I'm going to start out in terms of child neurologic disease talking about worms. And I want to talk about three worm diseases having big effects on the brain: hookworm, onchocerciasis through something called nodding disease, which has just emerged over the last few years, and then cysticercosis. So for hookworm is one of three major what are called soil-transmitted helminths. That is, the contaminating stages are in the soil. In the case of hookworms, they're usually penetrating through the skin. And basically every single child, like the children here that live in poor countries, are infected with these worms. This is an example of a study from Guatemala that we've done, but you can replicate this in almost any poor village in a resource-poor country, whether it's in Latin America, Africa, South Asia, or Southeast Asia, where you see age class 0 to 3, 4 to 7, 8 to 12, and there's prevalence, the percentage of kids of those ages that are infected with the worms. You can see basically everybody has Ascaris, and almost everybody has trichuris, hookworm, or strongyloides. And again, this is what we did in Paquila, Guatemala, but you can go anywhere in Guatemala or Central America or tropical regions of South America, into Southeast Asia, into Vietnam, Cambodia, Laos, into southwestern China, going into India and Bangladesh, or you get the picture, going into into Sudan or Congo or Angola, and of course all of the poor areas of Latin America, and everybody has worms. And it's particularly a problem among kids. So kids have more worms than adults. So, and it's the kids who get the sickest as a consequence. So I'm showing you a composite curve that we help to contribute to, where you have age on the x-axis, number of worms on the y-axis, and there's a peak of worminess in the life of these children between the ages of 5 and 15. Anybody know why? Why do children have more worms? Anybody want to venture a guess? Why kids have more worms than adults? Don't be shy. Hygiene is a good hypothesis. Any others? Playing outside, yeah. Immunity, yeah, as you get older, maybe there's some kind of immune response that kicks in. It's a trick question. I have no idea. These are neglected tropical diseases, and nobody looks. But why do kids have so many worms? And so what the worms are doing, each worm has a different effect. In the case of hookworm, it's causing anemia because the adult worms attach so deeply to the mucosa by those ugly-looking mouth parts. They actually extract blood out of the intestine, and we can show that the more worms you have, the more blood loss. So there's a longitudinal section of a histologic section of a worm attached to the inside of the gut, and then there's blood pouring out the other end. So each worm is causing about up to 0.2 mLs of blood loss a day. So you're getting a few mLs of blood loss a day, and this is causing iron deficiency and iron deficiency anemia. And the more worms you have, and we can use a surrogate measure using quantitative egg counts, because the worms are mating, they're producing eggs that are appearing in the feces. The more worms, the more anemia, the lower the hemoglobin concentration. Now, this has been known for almost 100 years, and it shows you that the more worms you have, the more hookworms, the greater your loss in intelligence. So worms are shaving IQ points off of kids. And anybody remember the number of people infected from that first slide? Ascaris was the 800 million, hookworms was about 470 million. So we're not talking a rare disease. We're talking about tens of millions, hundreds of millions of children in poor countries not living up to their full potential because they're having their IQs stunted because of worms, because of hookworms. So what's the mechanism? You know where this is going, right? We don't know, but what might be the mechanism? Wasn't that amazing? Arguably the world's leading cause of neuropsychiatric disturbance, and there's not really a single published paper on the mechanism. There are socioeconomic affiliations, but one of the things you can show is after you get rid of the worms, even though they come back, after you get rid of the worms, in some cases you can restore IQ and cognition, which is sort of not a perfectly, but a well-controlled experiment showing that it really is the worms. When we know poverty has additional effects as well. So why is it? Why would a worm in the gut produce losses in intelligence? Yeah, I'm wondering if it has to do with the iron deficiency and iron deficiency anemia, and maybe that's the mechanism that's doing it, but totally uninvestigated. So that's a huge problem. We're actually doing a lot of work to tease out how worms feed on blood. Over the years, we've dissected out all the enzymes that they use when they ingest blood. They break open the red cell and they degrade hemoglobin, and we've used that as a vaccination strategy. So I know you're not used to looking at CAT scans of worms, but this is on the lower right is a longitudinal section of a hookworm that's been removed from a vaccinated animal. So we can immunize with the enzymes that the worm uses to degrade hemoglobin. It takes up the antibody neutralizes the enzymes, stops it from feeding, and it dies. So we're using this as a hookworm vaccine that's now in clinical trials in this rural area of Brazil. This is one of the vaccines that we've made at the Feigen Center, and now we can show that it's immunogenic, and now we're looking to move this towards phase 3 studies for licensure for a hookworm vaccine, which we think will have a big impact on child neuropsychiatric health. And we're doing this as a consortium now with a bunch of European institutions, including the Albert Schweitzer Hospital now in Gabon, where we're continuing the study. So the idea is to make a vaccine that prevents worm-induced anemia. So that's, and now we've also found wherever we find hookworm, we're finding schistosomiasis. So we've got a second vaccine for schistosomiasis in clinical trials now in Africa and Brazil. And hopefully one day we can co-formulate, because schistosomiasis also seems to have some mental health effects as well. So that's worm number 1. Worm number 2 is river blindness, sort of. So river blindness is caused by Onchocerca volvulus. There are about 17 million cases annually. I wrote million. It must have been a moment of irrational exuberance. It's just million, just 1 million, 17 million cases, and predominantly in sub-Saharan Africa. There's a few remaining foci in Latin America, mostly on the Brazil-Venezuela border, and the microfilarial stages travel to the anterior chamber of the eye, where they die and they form punctate opacities that results ultimately in blindness, which usually is more late adult onset. We're doing a lot of work now with mass drug administration on ivermectin, even looking at the beginnings of an onchocerciasis vaccine, but that's not the part I wanted to talk to you about. The part I wanted to talk to you about is an observation that's been made over the last few years that's been noted in areas where onchocerciasis is highly endemic, in northern Uganda and now into southern Sudan. So it was first discovered in 2003, and it's something called nodding syndrome, which is believed to be a new form of epilepsy. And I'll show you some pictures. The symptoms include repetitive nodding of the head, reductions in intelligence, and stunted growth, mainly affecting school-age children between the ages of 5 and 15. And the nodding syndrome is characterized by paroxysmal spells of head nods forward repeatedly, about 5 to 20 per minute, and the child, when going through this nodding phase, is unresponsive and has decreased awareness, and sometimes it progresses to generalized tonic-clonic seizures, including, and it's considered a form of epilepsy, but it's associated with growth stunting, mental disabilities, failure to develop, and also noticed failure to develop secondary sexual characteristics. And that there's a child, they're drooling, having the nodding episode, and then I'm showing in the bottom right, if the child doesn't near an open fire, of course, there's a lot of risk of getting terribly burned. What's going on? And it seems to be very much in the onchocerciasis endemic areas. That's right, we don't know. But there's a few number of theories out there. the possibility that microfilaria are traveling to the brain of onchocercal volvulus. There's an interesting observation that when you give ivermectin for heartworm for treating dogs, there's one breed, a collie, if you give ivermectin to it, it causes seizures. So, and it's thought to be due to some genetic defect in the blood-brain barrier of collies that allows ivermectin to transverse, and then somehow this is causing some direct pro-convulsive effect. Could it be related to the ivermectin mass treatment? People don't like to think that because of all the effort invested now to use ivermectin as an elimination strategy. The other hypothesis that's been put out there is the black fly that transmits onchocerciasis is also transmitting a co-pathogen such as a virus that may be causing this. So this is relatively new, and we're just getting our arms around it, but it seems to be a pretty significant problem now in Uganda, in Sudan, and maybe elsewhere. Remember, where onchocerciasis occurs is not in user-friendly areas. It's in Central African Republic, it's in Congo. These are not easily accessible areas, so we really don't even know the full extent of the disease. There's been limited, because these are such difficult places to work, it's not trivial to get these kids in an MR scanner. There's been noted to be some cortical and cerebral atrophy, changes in the hippocampus and some gliatic lesions. But it's interesting that it has this tight association with river blindness. So this is kind of a work in progress. The other thing we've noticed about worms is wherever you have worms, you have malaria. And so I want to spend a few minutes talking about the impact of malaria on mental health, because there's so little that we know, and yet it seems to be so important. So, you know, there's 4 malaria species. The overwhelming one you need to be concerned about is Plasmodium falciparum, because this is the one. The others, Vivax-Ovale, only infect reticulocytes, so you'd never get high parasitemia, so the percentage of red cells infected is low. With falciparum, all red cells can be infected, and so you can get enormously serious parasitemias leading to death. And the infection is hyperendemic in many parts of sub-Saharan Africa, but it's seen, of course, in places in South Asia, even a few areas of the Americas. And with Plasmodium falciparum, what it does is after the parasite infects the red cells, it induces proteinaceous knobs to appear on the surface of the red cells, and that subsequently adheres deep in the vasculature. So what happens is, as the parasite develops in the red blood cells, you stop seeing the advanced forms in the peripheral circulation because they're all in the deep circulation, including the cerebral vasculature. So that's why a peripheral smear with somebody with falciparum malaria only has these ring forms, because as the parasites developed, it's going deep into the vasculature. And the peak period when children die from falciparum malaria is quite a specific window between around 8 months of age and 5 years of age. That's the peak period when children are mostly dying. Prior to then, it's thought that maternal anti-malarial antibodies are having some mitigating effects, and afterwards, when you're exposed living in the endemic area, you develop antibodies to the parasite through repeated exposure. But it's that period between 1 and 5 years of age that worries us the most. And one of the leading causes of death is actually cerebral malaria, neurologic illness. And it's argued that cerebral malaria may be the most common non-traumatic encephalopathy in the world. And so the majority of children who are dying of cerebral malaria. And what's amazing is how little we understand. I mean, arguably this is one of the most important pediatric neurologic diseases in the world, and it's still wide open in terms of what our understanding is. Here's what we do know. We have a fair bit of conventional pathology, neuropathology, histopathologic data, and it's associated with engorgement of cerebral capillaries and venules with those parasitized red cells. So those red cells that have the knobs on their surface, they're all sticking deep in the cerebral vasculature. It's known that the brain is usually swollen at postmortem, although the evidence of frank herniation is unusual. And then when you look at the brain, what you see is that it's gray. That's from all the deposition of malaria pigment. So what malaria does is it feeds on blood, human blood. And the heme component is very damaging to the malaria parasite. So it detoxifies the heme by polymerizing it into this inert pigment called hemozoin, which has a gray color, so that the whole brain looks gray in color. There's also petechial hemorrhages noted. The endothelium does not demonstrate microscopic damage, but there is some evidence of endothelial activation and disruption of the blood-brain barrier. Inflammatory cells immune complex depositions are not consistent features in necropsy. But there are some features of diffuse encephalomyelitis. So basically what you've got is you've got a gray enlarged brain with some petechial hemorrhages. That's about as much as we know. So the cerebral malaria is defined as a major cerebral event in patients with Plasmodium falciparum and no other explanation, seizures, and then subsequently coma. There's also, if the child survives, there's persisting developmental abnormalities, and the causes are known. Is it microvascular changes from the parasitized red cells in the vasculature? Is it metabolic with all that hemozoin pigment doing something? There seems to be, other than that, minimal histopathology, even though it's such a huge killer. We have somewhat of a breakthrough from Terry Taylor's group at Michigan State, where she's taken the time to do a lot of MRIs at her field site in Malawi. And one of the things that she's noticed is increased brain volume was seen in children who died from cerebral malaria, but was uncommon in those who did not die. Findings suggest that raised intracranial pressure may contribute to a fatal outcome. The natural history indicates that increased intracranial pressure is transient in survivors. So what we need is a really smart neurologist to put all this together, to kind of help us figure out how to connect the dots and say, okay, we're getting gray pigment deposited in the brain that's causing metabolic changes, you're getting microvascular changes, and now you're getting brain swelling. What's the pathogenic sequence of events? What's the actual cause of coma and death? And how can we reverse it? I think part of the problem is it's just so understudied, and that we just haven't launched a full frontal attack on this problem, even though it is probably the most important neurologic disease of kids. So again, a great hypothesis finding thing. What about some of these diseases in the U.S.? One of the new aspects of neglected diseases that I've been really focusing a lot on, and the subject of my next forgotten book, is this concept of we're finding this paradoxically high rate of neglected diseases, of poverty among the poor who live in wealthy countries. So what's happened is, I think, as a consequence of the Millennium Development Goal and all that overseas development assistance that's gone to Africa, it's had an impact, very positive impact. But it's like peeling away the layers of an onion, and the fact most of the world's neglected diseases today are actually in the G20 countries, the group of 20 countries, together with Nigeria, which is not a G20 country per se, but it has a bigger economy than the bottom four. And so the concept is this idea of developing versus developed is your father's global health or your mother's global health. What we're now seeing now is all economies are rising, but leaving behind a bottom segment of society. And this is a provocative map. I modified it a little bit more for the book, but it basically shows you pockets of extreme poverty and disease in wealthy countries. And so when you look at the G20 countries today, they account for half the world's helminth infections, most of the dengue, Chagas disease, leprosy, most of the tuberculosis, HIV/AIDS. So it's the poor living among the wealthy, and I call that concept blue marble health for reasons that we'll get into. Now you notice on the blue marble health map, there's a little bit of blue in the United States, and particularly in a state that has the most people who live in poverty, which is the state of Texas. So what we're finding, and that's one of the reasons why we created the Tropical Medicine School with Texas Children's and Baylor College of Medicine and the Texas Medical Center, is we believe that there was a hidden burden of neglected tropical diseases among the poor. So what I'm showing you For instance, on the upper right from a colleague of mine at the University of Texas at Austin, Dr. Sarkar, is a Chagas disease risk map. So we're finding high rates of Chagas disease, but also transmission. So, and that's very important because in this politically charged environment we're in now, the first thing that happens when I talk about these diseases is they say, what? It's due to, we got to build a wall higher, right? But I point out that 10% of the dogs in Texas have Chagas disease, and the dogs are not slipping in across the border from El Salvador and Mexico. We have transmission of those diseases here, and we're finding quite a bit even among hunters and campers and people who've never left the state. So Chagas disease is not is a cause of debilitating cardiomyopathy and heart disease transmitted by kissing bugs caused by a single-cell parasite called Trypanosoma cruzi. On the bottom there is a map from Christy Murray's work in our school that she's found that Houston had a dengue epidemic in 2003 transmitted by Aedes aegypti mosquitoes. So hold that thought when we talk a little bit more about Zika. So one of the things we've done now is create a tropical disease clinic for people with these diseases that are acquired here in Houston. It's not a traveler's clinic, but actually from people in Harris County with tropical diseases. And altogether, we estimate there's 12 million Americans living with at least one neglected tropical disease. And this is one I know you're very familiar with, Schistosomiasis, which is acquired by swallowing the eggs from someone who harbors the adult pork tapeworm, Taenia solium. And then the larval stages go to the brain, the eyes, or the muscles, and it's a disease when it's in the brain and the eyes called Neurocysticercosis. We're trying to understand how many people have this disease. It's caused, again, by one or more of these larval stages of the pork tapeworm. It's a leading cause of epilepsy, particularly among Hispanic children. It's now considered a major cause of epilepsy in Los Angeles, and I think there's probably a lot more of it in Texas than we probably realize. The characteristic feature is this ring-enhancing lesion, which is actually occurs in response to inflammatory cells that attack the dead and dying parasites. So it's not the living Cysticercus that's causing the disease. It's not the living larval tapeworm. As the tapeworm starts to die, it loses antigen masking properties, and a host of inflammatory cells come in, lymphocytes, plasma cells, eosinophils, and they release, and monocytes as well, and they release substance P. And it's substance P that seems to trigger the seizure focus. This was shown by Prima Robinson, who was with us, and now she's at MD Anderson. So that makes it an interesting problem in terms of treatment, because if I'm telling you that the inflammation in the seizures is due to the dead and dying parasite, what's the point of giving anti-parasitic chemotherapy? Here's another one of these ring-enhancing lesions seen on MR. So the decision to treat is complicated. It depends on the number and types of cysts, and also it's very important to give corticosteroids concurrently, because remember, the feeling is if you're going to give an antiparasitic drug, such as albendazole, there could be other cysts there that don't have that ring enhancement, and you're going to trigger new inflammation and potentially raise intracranial pressure. So the thinking is you want to give corticosteroids together with albendazole. And what I always tell people is make sure you do this in consultation with a neurologist. Surgical removal is unusual unless it's in a very sensitive location near intraventricular, intraocular, spinal cyst. And then you want to rule out any intraocular cysts, because that could trigger inflammation in the eye, and you could lose sight in the eye. So there recently in neurology, there were some clinical guidelines published for it as best we can, recognizing that this is still an under-investigated disease. And the recommendation is that albendazole plus either dexamethasone or prednisolone should be considered for adults and children with neurocysticercosis, both to decrease the number of active lesions on brain imaging studies and to reduce long-term seizure frequency. The evidence is insufficient to support or refute the use of steroid treatments alone in patients with intraparenchymal neurocysticercosis, but we generally recommend it. And the problem is it's not really clear at what point the steroids should be started. Now, an important piece to this is what's the efficacy of the antiparasitic drugs in treating or decreasing the occurrence of seizures, as well as anticonvulsant therapy. But the thinking is currently that there is benefit to adding antiparasitic therapy. Albendazole is kind of replacing praziquantel at this point. A big issue, though, is the continuation of anticonvulsants, because what happens is those lesions generally begin to involute and cause a small calcification, but it looks like that calcification can continue to throw off seizure foci. So oftentimes you have to keep individuals on anticonvulsants for years. The other one I want to leave you with for worm infections is this one, toxocariasis, which is, you probably haven't thought about it since medical school, which is a canine zoonosis. So all puppies and stray dogs, especially in poor neighborhoods, have worms that look like ascarid worms, but they're releasing eggs that are released in the environment. Kids swallow the eggs, they come in contact with them on sandboxes and playgrounds, and then the larvae hatch out of the eggs, and they penetrate through the brain, visceral organs like the liver, and even into the eye. The full-blown sequence of visceral larval migrans and ocular larval migrans appears to be a relatively rare condition, but we're learning now about a third form of the disease called covert toxocariasis that not many people know about, where a child will present only with developmental delays and some eosinophilia due to the larvae migrating through the brain over a period of years. So these larvae will continue to migrate for a very long time. And this first came to light from studies from the Centers for Disease Control that found incredibly high rates among non-Hispanic African Americans of 20% or more, with the highest percentage in the American South, with risk factors related to low household education, poverty, and elevated lead levels. And there was this curious association with toxoplasmosis, which makes some people think it's the cat roundworm rather than the dog roundworm that may be triggering this. Our estimates are there's 2.8 million African Americans living in poverty with toxocariasis. What's interesting is the studies coming out of SUNY Downstate showing that it's linked to developmental delays. Given how common it is, the big question then is Toxocara an environmental cause or association of poor school performance and cognitive delays in kids from low socioeconomic backgrounds? And so how many grants have been given out to study toxocariasis by the NIH in the last decade? That's right, 0. So how many about Ebola? Who knows? Lots, right? So this is what I mean by a neglected disease. So the point is, so here's a disease of 20% seroprevalence among African Americans. Seroprevalence is believed to be associated with ongoing active infection. It's been shown to be linked to cognitive and developmental delays. And we have this big question mark of, could this be an important contributor? So this is a study that we'd love to do, really pin this down a lot more, because the nice thing about toxocariasis is you could treat it with a week-long course of albendazole. And could that have an impact on improving cognitive outcomes in kids from socioeconomically disadvantaged backgrounds? So it potentially has huge implications, and is one of the diseases that I wanted to talk to you about, why I wanted to present to you today. I want to finish up talking about Zika virus, because I know you're going to be asked a lot of questions about it. Zika right now is hitting Brazil very hard, especially in the impoverished areas of northeastern Brazil, especially the cities. And that's because it's transmitted by an urban mosquito, Aedes aegypti, that lives in very close proximity to human dwellings. It's not like the Culex mosquito that transmits West Nile here. It specifically lives in human habitats and loves crowded conditions and poverty. And the reason it likes poverty is they live in the old tires and old TV sets discarded in and around homes in low-income neighborhoods and that fill with water, and then they go right into the homes that don't have adequate window screens. So it's been hyper-endemic in Recife and Salvador da Bahia, where over 60% of the population is becoming infected. The situation we're seeing is that this virus comes in like a train and infects a large percentage of the immunologically naive population over a short period of time. And a year ago, it was noted that babies were being born with microcephaly, having a head circumference 2 to 3 standard deviation below normal in those cities that I just showed you, Recife, Salvador, Bahia. So it's been very focused in northeastern Brazil, and I believe the poverty is an important link. So this is where the virus is spreading now in almost every Latin American country and Caribbean country. It's moved now into Colombia, and we just had a woman from Colombia give birth to a baby with microcephaly here in Texas that was reported this week. And so we're just now starting to see the epidemic enter into Colombia, Central America, especially Honduras, and into the Caribbean islands. So what we can expect is that one baby that we saw with microcephaly came from Colombia. We can expect it's going to be the first of many babies coming through. Now, we don't really understand why this virus has spread like this. If we had a longer time, I'd give you all the different theories, but one of the more prevailing ones is it looks as though when the virus came out of Africa during about 10 years ago and into Micronesia, French Polynesia, it underwent virus mutation in a gene called the NS1 gene, which is responsible for replication in mammalian cells that affected codon optimization of the virus. And now there seem to be some additional mutations in the NS1 gene as the virus has entered into Brazil. So this is a figure from a group at UCLA, which has been looked at the genetic sequences of 41 strains, and it seems very focused on that NS1 gene that is both responsible for its ability to replicate in cells and probably the neurotropism as well. So this is a highly neurotropic virus. So the link between microcephaly and Zika was shown first by the Brazilians that recovered Zika genome in the amniotic fluid of mothers who, by ultrasound, had microcephaly. The Zika genome in the blood of newborns, and the CDC confirmed it in the placenta. Now, the point that's very important to make here is everyone's focused on microcephaly and head size, but the really devastating association came to light when the first fetal ultrasound pictures came along, and there was, all that was left, in addition to having a small head, was massive ventriculomegaly and just a thin rim of cortical tissue. A group at Hopkins in Florida State has shown that this virus is selectively infecting neural progenitor cells, the stem cells that give rise to the fetal cortex, as well as associated with hypoplasia of the cerebellum and the corpus callosum. So there are massive deficits of the brain. So I think a better term that I like more, I see Gail Harrison's here in the crowd. I'd like to see what she thinks of it, is a paper I found from 1990 that I think is a much more apt description of what's going on with these Zika babies beyond microcephaly. And it was a group, a pediatric genetics group at Indiana University that called it fetal brain disruption sequence, where they described it as a recognizable pattern of defects that includes moderate to profound microcephaly, overlapping sutures, occipital bone prominence, and scalp rugae. The condition is postulated to arise from partial brain disruption. In this case, they said during the second or third trimester. I think for Zika, it's going to turn out to be more than the first trimester for reasons we can talk about, with subsequent fetal skull collapse resulting from decreased intracranial hydrostatic pressure. In other words, the brain hasn't developed, and the skull is essentially imploding on the absent brain. And at that time, proposed causes including prenatal viral or parasitic infections, and these are uniformly poor prognosis, and I think this is probably what's happening with Zika. It's essentially blocking the development of the fetal brain. We've known the calcifications are linked there, and these are some of the early cranial ultrasound pictures, this very horrible picture of big ventriculomegaly and absent cortical tissue. We've now gotten a few MRIs out that confirm a number of these findings that we can then subsequently go into the ventriculomegaly and the presence of the calcifications. So I wrote a piece on JAMA Pediatrics. We still don't know the percentage of babies who are born with fetal brain disruption sequence and microcephaly from mothers infected with Zika. The numbers coming out of French Polynesia suggest it's 1 in 100, but the numbers coming out of Brazil seem to be much higher, closer to 1 in 10. So this is a consistent pattern that we've seen. So Guillain-Barré with Zika is occurring 1 in 1,000 in French Polynesia, maybe as much as 1 in 100 in Brazil, but there's not a lot that's been published so far. So we're very worried between 1 in 100 and 1 in 10 mothers infected with Zika are going to give rise to this horrific congenital birth defect. One of the questions that we're also asking is for every baby with microcephaly and fetal brain disruption sequence is what about the 9 others who don't have structural changes on the brain, but we know this is such a neurotropic virus. Could there be other subtle but still profound neurologic deficits? And then another big question that we're going to need to ask is in the first year of life, when we know the brain of infants is still growing and developing, what's the consequence of pediatric Zika infection? Now, all of this is unknown. And I think it's going to be years before we sort it out. And then the people that are going to sort it out are the people in this room. We're very worried where this virus is going to go next. It's in Haiti right now. Haiti's got all of the factors that are associated with Zika. It's got the Aedes aegypti mosquito, the crowding and poverty. We're very worried for Haiti. It's right now in Puerto Rico, where the CDC estimates now there's about 25% of the island's going to become infected. The numbers that we're looking at in terms of microcephaly, fetal brain disruption sequence, go up to about 1,000 cases in Puerto Rico. And then the big question is where it's going to head next. I've told you that we have, it's where Aedes aegypti is present. You notice that rim of Aedes aegypti along the Gulf Coast. And so the big concern is, for us, is what's going to be the potential impact of Zika in Texas. Now, early on, the Centers for Disease Control said, don't worry about Texas, Louisiana, and Florida. Everybody's wealthy. Everybody lives in air conditioning. And so that's when I started taking people through some of the poor neighborhoods of Houston, and I'm sure you have them in San Antonio and elsewhere, where you can see it looks a little bit like Pernambuco State in Brazil, right here in Houston, where you have dilapidated housing without window screens, and again, enormous amount of dumping in poor neighborhoods. The tires, which is Aedes aegypti, have in the old TV sets plastic containers. So for all those reasons, I think we have the potential to start seeing transmission here. And part of the problem is without, Congress these days cannot organize a 2-car funeral. So they're unable to agree on any kind of appropriation for Zika funding, and they just went on recess for 7 weeks. So we don't have a lot of capacity at some of the local and county health departments to do the active surveillance for Zika or to do the Aedes aegypti control. Remember, it's not the CDC that's going to fight this epidemic. It's going to be people on the ground here. So this is one of the better maps that I've seen from Aedes aegypti from Simon Hayes' group, looking at where the big areas that are going to be of concern. And you can see that there's some of those blotches that you see in the red there inside Texas or around Dallas and San Antonio, so definitely Aedes aegypti there as well. In terms of what we're going to do about it, it's important to point out that the way we traditionally control mosquitoes here in Texas is, those of you who have survived our summers here know that when the trucks pull up at night, they lift up that big fog of insecticidal spray. That's going after the Culex mosquitoes that target West Nile. It does nothing for Aedes aegypti, or very little. So the way you control Aedes aegypti is you have to go house to house to house and remove plastic containers that have water or bird baths, and then do spraying in and around the home. And this was actually achieved in 18 Latin American countries during the 50s and into the 60s, where it led inspired by this man named Fred Soper, they launched military-style campaigns in out to 18 Latin American countries. At that time, it was targeting Aedes aegypti that transmitted dengue and yellow fever, and they were actually successful. They eradicated it, and it brought it down to near zero levels. The problem was the U.S. refused to play. So that in the 1930s, you had this huge problem. The Latin American countries agreed to eradicate the Aedes aegypti mosquito. The U.S. Did not participate, partly because they didn't see the urgency, and there's a problem with cultural norms of privacy. Apparently in Texas, people don't like it when you knock on the door and say, we're coming into your home to do some insecticidal spraying. That doesn't go over big in our state. So for cultural norms of privacy, we've refused to do it. So that back by the 1970s, the Latin American countries were publicly complaining about the Gulf Coast of the United States was the source of reinfestation of Aedes aegypti mosquitoes all across Latin America. Again, they were being sent down in the used tire trade. We helped to create that. So and that's a long way of saying we've never done Aedes aegypti control in this country. We don't know how to do it. The expertise, money aside, the expertise isn't there. So if we start seeing Zika transmission on the Gulf Coast, we're in for a very long and difficult period. And the point, what I'm concerned about now, that and given the absence of funds, we may not even know Zika transmission is here because nobody's doing active surveillance, and we could talk more about that. So the nightmare scenario that I'm worried about is not knowing Zika's here until you get called as a consultant to a case in the labor and delivery suite of a baby with microcephaly 7, 8, 9 months from now, because we know historically from arbovirus infections with West Nile and with dengue that in Texas they start peaking around July and August and go into September. So this is the time when transmission's beginning. So the real terrible period I'm worried about is towards the end of the year or early into next year. So I'll stop there. I know I'm the only thing between you and lunch, and if you'd like, I can answer a few questions. And I thought it would be useful to give that kind of 30,000-foot overview of what I see are some of the big global health neurologic issues. Thank you very much. Yes.
Thank you for coming and talking to us. I've just got a strategic and a strategic change that might lead to more funding and more attention to Zika. I think our problem has been it causes microcephaly, small heads. The wording should be it causes brain damage. When you start talking brain damage, people get excited and interested. When you talk about small heads, we understand what that means, but politicians don't, and I think if we change the wording a little bit, it would get some more attention.
Yeah, lately when I've talked to journalists, I don't call it microcephaly, I call it fetal brain disruption sequence, meaning that they recognize that there's something going on with the brain. It's not just wearing a small hat.
Specifically, I was talking against that wording. That wording is great for researchers and scientists, but on NPR or on Houston Matters, it's brain damage that will get people interested.
Thank you for that suggestion. Other questions? Well, great. Thank you again for having me speak to you today.
Okay, so please enjoy your lunch. Remember your CME forms, and tonight our welcome reception party at 5:30 p.m. It's been a pleasure having you all here.